So I had a case actually yesterday that was kind of representative of a lot of things. She's a 50-year-old lady who actually was a breast cancer treatment patient. She just had a mastectomy, and she was there because she was having pretty terrible right shoulder pain. And she'd been having this right shoulder pain that was totally out of the blue for her for like about a week. And she thought it started after she did a particularly fun Zumba class, but it wasn't using weights or anything. And she was just kind of perplexed by it. I went and saw her, and her shoulder was really tender right over the biceps tendon near the shoulder. And she had pain with range of motion and all. We got x-rays, they were fine. And so my diagnosis for her was, well, ma'am, I think this is musculoskeletal syndrome of menopause. And she's like, what? I didn't know that was a thing. And the resident was like, what? So yeah, that's kind of a representative scenario of how menopause shows up in so many different organ systems.
Welcome to EM Pulse, bringing research and expert opinion to the bedside.
We're your hosts, Sarah Medeiros
and Julia Magana.
Welcome back to EM Pulse.
Today, guys, we're going to tackle a topic that honestly doesn't get nearly enough airtime in training or in our clinical pearls, and that is the gynecological health of the older woman.
And I personally am so glad we're doing this as someone who is currently navigating the joys of perimenopause myself. I have realized that what we are taught in med school is just the tip of the iceberg. It's not just hot flashes, it's a total systemic shift that completely changes how these patients show up in our ER.
Yes, exactly. There is so much nuance here that we often overlook. So to help us navigate all of this, we are thrilled to welcome Dr. Pam Dyne to our podcast. She's a professor of clinical emergency medicine and the chief physician wellness officer at Olive View UCLA Medical Center.
So, Pam, why is it important for emergency clinicians to know about menopause? It's not exactly the first thing that springs to mind as an emergency topic.
I have to say, Sarah, when you proposed this topic, I was like, okay.
Well, yes, it's not really an emergency topic, as in there's no actual emergency menopause treatment.
Yeah.
But there are a gazillion symptoms of menopause and premenopause or perimenopause that are just tremendously varied and can be similar to or actually mimic many actual emergencies like cardiac and neurologic events, musculoskeletal things. Certainly we see a lot of that in the emergency department, but even other diagnoses like carcinoid and hyperthyroidism, and then even if you get more into it, endometrial and ovarian cancers. So we really have to know and be familiar with the gamut of symptoms that can be attributed to menopause and perimenopause so that after we rule out the bad stuff, because we still have to do that, we can adequately counsel our patients about potential or maybe the actual cause of their symptoms that they're there and are concerned about. I mean, you know the situation. After a big negative workup or broad differential, you go back to the patient and say, hey, great news, everything's normal, right? And then they're like, so what's causing my symptoms? And you're left with that sinking feeling of like, I don't know, but it's nothing bad, so we're good, right? But that always leaves people feeling really hollow. And, you know, I've been practicing emergency medicine for like 30 years now, and it really helps me continue to find joy in practicing emergency medicine and teaching emergency medicine to really be more knowledgeable about a variety of things so we can help the patients navigate their symptoms. And this is one of those situations. Menopause, as you probably know if you're on social media at all, is really having a moment right now. And patients are becoming maybe more informed about it, depending on your patient population. And we should encourage them to talk to their PCP about it. Truthfully, their PCPs may not actually know that much about menopause because they were never taught about it in their training. And so we can really help the patients to feel more empowered to talk to their PCP about their symptoms. So in case you're wondering, here's the gamut of symptoms that might show up in your emergency department that are related to menopause and perimenopauses. The obvious, sort of the vasomotor symptoms that we all have heard about, hot flashes, of course, insomnia, night sweats, etc., but lightheadedness, headaches, irritability, depression, anxiety, mood changes, weird aches and pains, backaches, joint pain, muscle pain, weird skin stuff like feeling tingly, and of course, urinary symptoms as well. So yeah, it's a lot of things that seem like a lot of other things. And so we kind of have to know these things.
Okay, that's a lot, Pam. I can't wait. Can you give us a quick refresher on what actually happens in the female body as we go through menopause?
Yeah, sure. So menopause is basically the ovaries retiring. Women, as you'll remember, are born with all the eggs they'll ever have. And over the course of their life, during the reproductive years, that supply gradually depletes. And once the ovaries run out of functional follicles, the whole hormonal system that depended on them just shifts dramatically. Do you remember from physiology class, there's the ovarian pituitary axis, right? So during the reproductive years, the ovaries and the brain are in constant conversation. The brain sends signals in the form of FSH and LH, those hormones that the pituitary makes, telling the ovaries to develop eggs and produce hormones. And then the ovaries respond by releasing estrogen, and that tells the brain, hey, message received, we're good, dial it back. And then when the ovaries are no longer responding, the brain just keeps shouting louder and louder. And that's why FSH goes up in menopause, because the brain is basically saying, hey, we're trying to do something here and nothing's happening. So that's basically what's happening. So FSH is high in menopause, but during perimenopause, it's kind of all over the place because the hormones are shifting. It's totally inconsistent. Sometimes there's estrogen, sometimes there's progesterone, et cetera. And so that's why our bodies get a lot of weird symptoms during perimenopause as well. Progesterone, I mentioned, is made by the ovaries after ovulation. So once ovulation stops, progesterone basically disappears. That's why during the perimenopause years, your cycles start to become irregular because ovulation is sort of hit or miss. And so you get stretches of unopposed estrogen with no progesterone. And so bleeding can become unpredictable and irregular and sometimes heavier. So those are basically what's happening there. Did you know that women actually make testosterone too?
I think I remember that, yeah.
Yeah. So it's primarily made in the ovaries and also the adrenal glands, and that goes down with age. But the ovaries keep producing some testosterone even after menopause. And that's actually one of the reasons that women who have a surgical menopause, when their ovaries are removed, they tend to actually feel much more abrupt and severe symptoms than those who go through natural menopause.
So it's kind of like that cell phone signal is like in and out, and your brain is like, ovaries, can you hear me now?
Right.
Can you hear me now?
That's exactly right. And the other person is like shouting like, I can hear you, but you can't hear them. All that. Exactly. Yeah.
So Pam, you've talked about a million different kind of vague-ish symptoms. How in the ED are we supposed to know or think about that, like, oh, maybe this is menopause or perimenopause?
Well, like all the things that we consider, there's a broad differential diagnosis for many of the complaints we have, right? So epigastric pain has a differential diagnosis, right? You know, we got to rule out the bad stuff. Is this cardiac, right? In the right setting? Is this biliary colic or cholecystitis, right? And once we've ruled out the bad things, then we're like, oh yeah, well, it's probably dyspepsia, right?
Mm-hmm,
right?
Mm-hmm.
I mean, that happens every day. The chest pain, like, what is this? Is it cardiac? Once we've ruled out the bad stuff, then, well, maybe it's musculoskeletal. It's the same kind of thing. Once you've ruled out the bad stuff, well, maybe this is menopause. We just have to keep it in our differential diagnosis.
Yeah, I really like that. As you were talking, I was like, I think the point of this is put menopause or perimenopause on your differential diagnosis. And then just like everything else we do, you're going to approach it in the same way. So that's nice and clean and simple.
Yeah, have that high index of suspicion. So, you know, we know that a lot of our patients may be on hormone therapies to treat a lot of these symptoms, or maybe even medications like SSRIs to help them manage. What do we know about these treatments and any potential side effects?
That's a really great question. And I would love it if actually our patients were on the hormone treatments, because many of them are not. But the most important thing to know about the hormonal treatments is that they're very safe, okay? And they don't increase the risk of cancer for the vast, vast majority of people, especially when someone doesn't have a personal history of cancer. The reason that many people are not on these medications or they kind of get a bad rap or think they're dangerous is because there was a whole pile of misinformation in the early 2000s. Remember the early 2000s? Because there was a huge study that came out in 2002 called the Women's Health Initiative. And at that time, actually, many, many women were on estrogen therapy for menopause symptoms, and they were feeling great about it. But it had never been actually studied in a comparison to see what potential long-term effects were. Okay, so that's why the Women's Health Initiative, among other things, was done. And so they studied actually a much higher dose of estrogen that's currently being recommended. And they also studied kind of an older patient population than most people consider a menopausal patient population. So it was weird because the study was ended early because early reports suggested that there was a trend towards increasing incidence of breast cancer and heart attacks in the study group. So the media got hold of this and it caused mass hysteria. And so millions of women had to throw out their hormone replacement therapy, and then 20 years worth of trainees never learned about it. And then in 2022, the data were reanalyzed and reinterpreted. And it turns out that estrogen is actually extremely safe for women in a particular age group. In fact, in women who are aged 50 to 59 and less than 10 years after their menopause, had a reduced incidence of ischemic heart disease, Alzheimer's disease, Parkinson's disease, and osteoporotic fractures of the spine and femur. And there was actually a 30% reduction in all-cause mortality in these women. So the reason I'm very specific about it should be started before 10 years after the menopausal transition is because actually if it started after that, estrogen can be actually pro-inflammatory. There's a timing effect is what it's referred to. So the current consensus is that for healthy people born female, younger than 60, and within 10 years of the menopausal transition, the benefits of hormone therapy outweigh the risks. Okay. And so this update was a significant rewrite to prior recommendations. And this is now what all the providers who treat menopausal women are shouting from the rooftops, is saying that it's totally safe and people should be on hormonal treatment for menopause as long as they want to, provided it was started before 10 years after their menopausal transition or before they're 60.
So what does that mean for us in the emergency department? Is that something, Pam, that you start patients on? Like that patient that had musculoskeletal pain, is that somebody that you're going to have a discussion about treatment options on?
No, I don't feel like myself as an emergency physician, I would prescribe menopausal hormone treatment because there's a lot of nuance to getting the dosing correct. And there's a lot of options. So they need to find a provider who will treat them with hormones if it's appropriate for them, to at least have a discussion. The patient I was talking about at the beginning actually is a breast cancer treatment patient. So that requires some nuance as well. But, that's a discussion for people who are specifically trained in that, right?
Yeah.
And that's not me as an emergency physician. But it's pretty easy to find a menopause certified healthcare practitioner in your area. You go to menopause.org, and that takes you to the homepage of the Menopause Society. And then there's a whole list of find a healthcare practitioner.
So as this data kind of trickles down and hopefully more people are learning about this, we should be seeing more patients coming in on hormonal therapies. And obviously, as you mentioned, there's some nuance for certain patients where specific risks might apply. But in general, what kind of downsides do these treatments potentially have, or like side effects that we might see in the ED?
So when estradiol, which is the usual estrogen form that's prescribed, is first started, they can have irregular bleeding, breast pain, nausea. And it's important to know that just being on estradiol alone can cause endometrial hyperplasia. So if a woman has a uterus, they need to also be on progesterone along with their estrogen. So those are the side effects of the estrogen. Side effects of progesterone when it's first started are mood swings, bloating, and sleepiness. In fact, it's very much recommended that people take their progesterone at night because it helps with sleep, which is actually a good side effect. And I'm sure you know that estrogen can cause blood clots, but that's actually estrogen when it's taken orally. And that's actually not true for transdermal estrogen, which is the form that most people get started on when they're on menopausal hormone treatment. And this is because it eliminates the first pass effect. And so there's really no increased risk in venous thromboembolism when someone's on transdermal estrogen. And another formulation of estrogen that pretty much everyone should be on is actually vaginal estrogen. It's a cream. It comes in a lot of formulations, and we can talk about that. But that estrogen is not absorbed systemically. It's only locally affecting the vagina, the vulva, the whole areas where it's put on. And so there's really no side effects at all of that. And everyone should be on that.
That's interesting. I didn't know that about the transdermal piece of it because I also trained in the early 2000s when that was the hot news. So if it's on our differential that some of our odd signs and symptoms could be caused by menopause or perimenopause, are there any other historical questions that you recommend we ask as we try to figure this out?
Yeah, you can ask about just a whole review of systems, basically, right? So you can ask them about, what's their period history, but then lots of symptoms happen, as I mentioned. So hot flashes and night sweats. Are they having any vaginal or urinary symptoms? So the vulva, the vagina, the bladder, they're all loaded with estrogen receptors. And so without estrogen, all these tissues really thin out, dry out. The pH of the vagina tends to rise. And so then there's a whole constellation of symptoms that are called genitourinary syndrome of menopause, or GSM. And so asking about just anything related to the vagina. There's asking about symptoms related to their brain functioning and mood, right? Because estrogen influences serotonin and norepi and acetylcholine. And so then people feel this in terms of poor sleep, poor mood, or changes in mood, cognitive sharpness. People really talk about brain fog. That is a real thing that has a biologic basis. It has to do with all these changes in hormones related to the loss of estrogen.
So, for example, that MSK patient, how did you go back to that this may be related to menopause?
It's just knowing that the MSK syndrome of menopause is a thing, right? Just like everything else in a differential diagnosis, you just have to know it's a thing to put it on your list of things to consider as causes of this patient's symptoms. I don't know for sure that that's the cause of her symptoms, right? What I know is it's not a pathologic fracture. She's a breast cancer patient, so we did an X-ray. It's very possible that she has and it is still potentially because of menopause, ligamentous injury or tendinopathy.
Is it just because of her age that made you think that this could be perimenopause?
It was basically because of her age. And I did ask her menstrual history, and she hadn't had a period in about a year. Welcome to menopause, because that's the definition of menopause, which I guess we didn't say before.
I think this kind of highlights a great opportunity that we have as ER physicians, because there may be a lot of clinicians out there who aren't necessarily treating menopause and perimenopause symptoms, or maybe not recognizing this as part of the etiology of people's symptoms. And that probably is due to a lack of training on this subject. So if you do know about these things, and hopefully after listening to this episode, you'll know more, it is a real opportunity to actually have that conversation with your patient and maybe suggest that they talk to their PCP a little bit more about this, or their gynecologist or whoever.
Yeah, that's exactly right.
So I think that's awesome. So Pam, talking about the physical exam now, like this is always a challenge. We do tons of pelvic exams in reproductive age females, but I see a lot more hesitation when it comes to doing pelvics in our older patients. So does every older woman need an exam? What are we potentially missing if we defer that pelvic?
That's a really great question. You got to ask yourself, what am I actually looking for on a pelvic exam to understand if it's indicated, right? So depending on what the patient's there for, right? If she's there experiencing postmenopausal vaginal bleeding, they absolutely need a pelvic exam to evaluate for cervical or vaginal cancer. And not doing the exam for whatever reason, because it's inconvenient, because the patient doesn't really want it, because you think they don't want it, et cetera, really potentially risks delaying a diagnosis of cancer. If the symptom that the patient's there for is vaginal or pelvic pain, I personally think you got to examine the thing that hurts, right? So again, we're looking for cancer or potentially pelvic organ prolapse, potentially torsion, or still, older women can get PID and potentially tubovarian abscess. So not every single person needs a pelvic exam, but if it's painful down there, I think you got to look. If it's bleeding down there, I think you got to look.
Pam, I don't know if you know this, but I actually don't see adults. But I walked into the pod the other night and my colleagues were discussing a older woman that had been transferred from a facility with blood in her diaper, and she's there with altered mental status. I was like, how are you going to do that pelvic exam? That sounds like a really big challenge. What are some of your best tips for examining that area in our older patients?
Yeah. So I don't know about your ED, but does your ED have all the gurneys have stirrups?
No.
Probably not, right? Maybe one bed has stirrups if you're lucky. They're definitely in short supply. And so sometimes pelvic exams are done by putting a bedpan upside down underneath the patient's butt so that you can have space for the handle, right? The whole reason we do that is so we can have space for the handle to point down. But that's really hard to put an older woman onto an upside down bedpan, right? I don't know if you've ever had an exam like that, but it's super uncomfortable. You have to have a lot of balance to keep your pelvis up like that. And it's hard on your hips. So if you're older and have some hip arthritis, et cetera, it's just like not a thing. So a tip I have is to actually not put them on a bedpan, just put their butt on the bed and then kind of get them so that their feet can be on the bed with their knees bent. But then if you just put the speculum in that way, the handle would be, hitting the gurney. So you know what you can do? Turn the whole speculum upside down so the handle is facing up. But you don't want to act like it's a laryngoscope. You don't want to pull up, on that, because then you're hitting their clitoris and stuff. That's not pleasant. So push down with the bottom part of the handle instead of pulling up on the top part of the handle, if that makes sense. And so that's a trick there. Use lots of lube as well. And you can actually, if it hurts to just enter the vaginal introitus, you can put some topical lidocaine gel on there too, so that it's not so painful. If the patient's cognitively impaired, you might need to sedate them for this. That feels kind of invasive, but sometimes you just got to get it done, right? Also, if you're really having a hard time getting the speculum in, consider that there might actually be something in the way, like a fecal impaction or a rectocele that's pushing up on the back wall of the vagina. So maybe look in the rectum. Another trick, if the patient really can't get comfortable with their hips flexed, so their feet can be on the gurney, so their hips and knees are flexed, is actually have them lay in the lateral decubitus position on their side and then have somebody hold their top leg up. Basically, they're in the lithotomy position, but on their side. And then you can do it that way.
I've never done that one before. I've done those other things, but that's interesting.
Yeah, I love these creative tips because it really is so important. I remember my great anecdote from residency. One of my good friends and co-residents, we were on internal medicine together, and overnight she admitted an 80-year-old patient with recurrent UTIs. And when she was presenting the patient the next morning, she was like, yeah, so, and then I did a pelvic exam, which she obviously probably had to do some of these tricks and be creative to do it. And I found this old pessary that had been up there for ages. And the whole medicine team just kind of gaped at her. Like, you did a pelvic on an 80-year-old? But it was super important and it made all the difference for that patient. That's
super interesting.
Okay, so let's move on to that big red flag that you mentioned, postmenopausal bleeding. So, as I've always been taught, this is cancer until proven otherwise. So what does your workup look like for these patients in the ED?
Yeah, so once the period stops, it's not supposed to start again, right? And so, yes, it's going to be cancer until proven otherwise. But that said, actually, the most common cause of postmenopausal bleeding is a pretty benign cause, which is just vaginal atrophy. That's not that terrible a thing, but the big thing we need to rule out is cancer. So you really need to examine them. Postmenopausal bleeding is actually pretty common, affecting 20% of women. And like I said, the most common cause is vaginal atrophy, but 10 to 20% of women with postmenopausal bleeding are going to have cancer. So it's ultimately diagnosed with an endometrial biopsy, but first they generally need to have an ultrasound to look at the thickness of the endometrium. So my workup in the emergency department is first a physical exam, including a speculum exam and a bimanual, just to confirm where the bleeding's coming from, make sure there's no other, because there's a differential. Is there a vaginal lesion that's bleeding, or a foreign body, or an old pessary, that kind of stuff. And then I generally get an ultrasound in the emergency department. Does it really and truly need to be done in the emergency department? no, it's not really an emergency to rule out cancer, but it really depends on the patient's access to close follow-up and the ability for them to get an outpatient ultrasound and their health literacy. So you kind of have to know the situation and the patient and what they would be able to navigate as an outpatient.
Okay, so in the end, I think that lady that presented with vaginal or bleeding in the diaper actually ended up being from an abnormal urinalysis. How do you decide if that patient has a UTI, and when might you consider withholding antibiotics?
Yeah, that's a controversial and kind of tough one. So the genitourinary syndrome of menopause can cause symptoms. Just that syndrome can cause symptoms that are similar to a UTI and can also cause recurrent UTIs. So both the same symptoms, but it's not really an infection, but also recurrent UTIs, real infections. So it's kind of complicated. And menopausal women tend to get frequent UTIs because of the changes in the vaginal flora and the vaginal pH and such, and also because of the changes in pelvic floor musculature that can cause urinary incontinence or retention. And so all those symptoms are symptoms of UTIs too, right?
Yeah.
So how do you decide, right? Well, you kind of have to go with the urine culture. That's the definitive diagnosis of a UTI, but we don't get the culture in the emergency department. So my perspective is if they have a positive urinalysis, positive for looking like an infection, go ahead and treat pending the culture results. But what's really important to ask her is if she's getting frequent, like recurrent UTIs. And if so, tell her she should be on vaginal estrogen, and that might actually prevent future UTIs. And she should talk to her primary care provider about that.
Yeah. And Pam, you have talked about vaginal estrogen, I think, a few times. Tell us a little bit more about the role of vaginal estrogen in these postmenopausal patients. And is this something that you're actually prescribing from the ED?
Yeah, you can. You can totally prescribe it from the emergency department. If someone's getting frequent UTIs, which has a specific definition, frequent UTIs equals 3 culture-proven UTIs in 12 months or 2 in 6 months, then actually the primary treatment is vaginal estradiol. And it's a totally reasonable strategy, with the exception of if they have urinary incontinence. Those women need a different management, but it's definitely adjunctive and actually preventative for recurrent UTIs. Vaginal estradiol is what's prescribed. It comes as a cream, which is used twice a week. It's just inserted with a little applicator. It also comes as a ring that stays in for 3 months, which is way less complicated and has better compliance than the cream, but the cream is really cheap and the ring is not. Those are the 2 primary formulations.
How long do you prescribe a course for from the ED?
So I give a one-time prescription for a tube of the vaginal estrogen. It comes with the dilator, and then they need to follow up with their primary care provider.
Okay, I hear another common complaint in an encounter is a bulging mass, like a vaginal bulging mass. Can you break down the different types of prolapse that we might see and how we should manage them?
So because the pelvic floor becomes weaker over time because of, in addition to menopause, but because of childbirth, because of chronic constipation, etc., lots of things can fall down.
Oh.
So there can be prolapse of the uterus, there can be prolapse of the bladder, and so that actually prolapses into the anterior vaginal wall, and that's called a cystocele. The rectum can prolapse into the posterior vaginal wall, and that's called a rectocele. And then vaginal prolapse itself can happen, and that's associated with hysterectomies. The symptoms are going to be pressure, incontinence, feeling this mass. They might have issues having bowel movements. They might have incomplete bladder emptying. They might have some bleeding and some vaginal discharge. Sometimes these symptoms are worse later in the day because of gravity, right? And also because of gravity, they can be tricky on physical exam because the patient might say, hey, when I'm standing, I feel this mass, but then you examine them laying down, right? And so what happens is it goes farther up. And so it's not as obvious. But you have to look. If they say I'm feeling this mass and I'm feeling this, bulge, and then you're examining them in the supine position and you don't see it, ask them to bear down and see if it kind of falls into place.
Yeah, and this is not something that's going to sort of improve on its own.
Right.
So I think this is a really important time to place a referral to our Urogyn colleagues or talk to the patient about, discussing this with their PCP and getting a referral, because this is not something that's going to improve.
You can't kegel it away.
Not usually, no. You can't kegel it away. It sort of depends on the severity, what the treatment's going to be. If it's mild, the symptoms, it might just be observation. But if it's mild to moderate, there's actually something called pelvic floor physical therapy. There's specific physical therapists who are trained in this technique to basically improve this. But if it's actually moderate to severe, they might need surgery, which might include a pessary.
Is this another one of those things that vaginal, intravaginal estrogen can help improve? Or is it like once it starts prolapsing, there's no real way back?
I think that once it's to the moderate to severe, there's no way back. But vaginal estrogen is good for everybody, so I'm not going to say it's not useful.
Okay.
And then, Pam, bringing it back to that patient that you initially spoke about, tell us a little bit more about this musculoskeletal syndrome in menopause.
It's a variety of aches and pains, right? It's really a bummer because things just hurt. And, but it's weird because it's often the shoulder. And it can be really debilitating because, you can't drive, you can't, if it's your dominant hand, you can't write. There's nothing specific about it. It's just happening because there's estrogen receptors all over the body, including in our MSK system. And so things just hurt for no good reason. And that sucks.
And there's actual inflammation.
Yeah. It's generally speaking a tendinopathy. So yes, there's inflammation, but it's not like you're going to see it on ultrasound or, or a lab change or on x-ray or et cetera. It's a tendinopathy.
Yeah. And then, of course, we also have to think about osteoporosis.
Oh, yes. Estrogen is protective of the bone loss, right? So estrogen basically functions in helping our bones in their normal metabolism, right? So we're constantly putting on bone and breaking down bone. That's just the bone metabolism. But when estrogen drops, then there's more bone reabsorption, especially in the first few years after the final period. And so women are just at higher risk for osteoporosis. Being on estrogen and working hard to maintain our muscle mass and doing weight-bearing exercises so we can continue to build muscle and maintain our healthy bone is really important. And getting followed for this. All women should have a DEXA scan, know what their risk of osteoporosis is and get treated for it if it's already happening.
Okay, Pam, wrapping it up. If you could give our emergency medicine clinicians one major takeaway about caring for the older female patient today, what would it be?
My one major takeaway is don't dismiss her symptoms. It's important for patients to have an understanding of what might be causing their symptoms, right? Even if once we've ruled out badness, that's our job, right? We're ER docs, we rule out badness. Her symptoms are still real, and she deserves to know that there's a potential cause for them. So educate yourself about it, and then ask your patient about her menstrual history, her sexual history, and tell her to talk to her primary care provider about it. If she doesn't have a primary care provider, then help her connect to care rather than just saying, hey, this dangerous thing isn't going on today, so you're good. There are lots of great menopausal providers out there, and you can help her connect to someone who will support her.
Yeah, I love that. Pam, thank you so much for sharing your expertise with us today. I feel like I just got a master class in this conversation here. And honestly, I'm taking notes for both my patients and myself.
Awesome.
I think there's several takeaways, but I think first and foremost is keep menopause on your differential diagnosis. Ask those questions, even if there's weird stuff that's going on. And we still have to do a physical exam. If it hurts, look at it, essentially, right?
Yes. If it's hurt, look at it. If it's bleeding, look at it.
Right. And also don't be afraid of intravaginal estrogen.
Intravaginal estrogen for everyone.
Right, yeah.
You get some intravaginal
Everybody
estrogen.
gets
you
it.
get intravaginal
That's actually
estrogen.
like so funny because lots of menopause podcasts talk about that. Like just like Oprah, you get a car, you get vaginal estrogen, you get vaginal estrogen. It's super cheap now and everyone should be on it.
Thank you so much for being here, Pam.
My pleasure. Thanks for having me.
And thank you to our department for caring for our perimenopausal and menopausal patients.
And thank you to OM Productions for making this all happen.
Until next time, stay curious, stay inspired, and stay tuned.
The opinions expressed on this podcast are those of the hosts or guests and do not necessarily reflect the views of UC Davis Department of Emergency Medicine, UC Davis Health, or their parent organizations.